Hello everybody. During this lecture, we're going to be talking about fluoroquinolones and some other classes of antibiotics. This is being presented by Austin Pates, PharmD, and a PGY1 acute care pharmacy resident at Moses Cone Hospital. Slides were adapted from those by Emily Stewart, PharmD, who is currently an infectious disease pharmacist at Moses Cone. Fluoroquinolones work by inhibiting both DNA gyrase and topoisomerase 4. These enzymes work during the DNA replication process, so inhibiting them ultimately blocks DNA replication, which results in cell death. Fluoroquinolones are a very broad and diverse class of antibiotics, with a wide variety of clinical uses and spectrum of coverage, which is highly variable depending on agent. In terms of coverage, they almost all have gram-positive coverage, including MSSA and Streptococcus species, and only delafloxacin has MRSA coverage. In terms of gram-negatives, they all cover Enterobacterales species, such as E. coli, Klebsiella, and Proteus. Ciprofloxacin and levofloxacin also have pseudomonal coverage. Delafloxacin also has in vitro activity against Pseudomonas. They also have good atypical coverage, such as Legionella, Mycoplasma, and Chlamydia species, such as those you might see with pneumonia. Moxifloxacin and delafloxacin also have anaerobic coverage. As I mentioned previously, they have a wide variety of clinical uses, again depending on agent. In terms of community-acquired pneumonia, levofloxacin and moxifloxacin are considered the respiratory fluoroquinolones. This is because ciprofloxacin does not have good strep pneumo coverage and should not be used for community-acquired pneumonia. For UTIs, moxifloxacin is not an appropriate agent, as it does not penetrate the urine well. Levofloxacin and ciprofloxacin would be the preferred fluoroquinolones for UTIs. In terms of bacteremia, they are often seen as a switch from IV to PO therapy, as they have a very high serum concentration in the blood, which means they can be used effectively for bacteremias. MRSA skin and soft tissue infections, again, are only going to be covered by delafloxacin. However, you're very rarely going to be seeing this agent used, as it has such a broad coverage, and there are other agents that may be more appropriate. So why do we not see fluoroquinolones used all the time? Well, there's a number of reasons, primarily related to their adverse effect profile. Fluoroquinolones are associated with CNS effects, especially in the elderly, and especially with the use of ciprofloxacin. These may present as headache, dizziness, hallucinations, and confusion. There's also the risk of GI upset and C. difficile. So if patients are presenting with persistent diarrhea, you should advise them to see a healthcare provider and be screened for C. difficile so that treatment may be initiated promptly if indicated. There's also the risk of QTC prolongation. It is especially a high risk if patients are already having a wide QTC, or there are other agents that may cause this effect, such as antipsychotics, methadone, or Zofran. Furthermore, there is the risk of peripheral neuropathy and tendon rupture. Usually it is appropriate to advise patients not to engage in explosive activity, as this may increase their risk of tendon rupture. Furthermore, it's contraindicated in pregnancy and in children. In terms of administration, there is the risk for fluoroquinolones to be bound by di- and trivalent cations, decreasing PO absorption and therefore therapeutic efficacy. You should advise patients to take antacids, milk, and multivitamins 2 hours before or 6 hours after administration of fluoroquinolones to prevent these drugs from being browned. There's also the potential for drug-drug interactions, such as warfarin, theophylline, and antiarrhythmics. Be advised that there are renal dose adjustments for many of these medications, except for moxifloxacin. As I stated previously with bacteremias, they have a very wide volume of distribution, and so not only do they get into the blood well, but they also have good penetration to the tissue and bone. As I stated previously, this is a pretty diverse class of antibiotics in terms of what coverage they offer. As such, it is important to check to make sure not only is the organism you're targeting being covered, but also the site of the infection. Recall that ciprofloxacin does not have good coverage against strep pneumo, so it may not be appropriate for respiratory infections. Likewise, moxifloxacin does not penetrate the urine well, and so it would not be appropriate for urinary tract infections. When in doubt, always check the spectrum of activity as well as the site of infection to make sure these agents are appropriate. Furthermore, consider patient-specific factors and the adverse effects that we've discussed previously to make sure these agents are appropriate for your patient. The next class of antibiotics we'll cover are the tetracyclines, which work by binding to the 30S subunit of the ribosome and inhibiting protein synthesis. As such, these are considered bacteriostatic agents. Here's a question to test your knowledge. True or false? Tetracyclines can cause tooth discoloration. We will revisit this question in the next couple of slides. Tetracyclines are a pretty broad class of antibiotics, with a couple of them being represented here. Doxycycline, or Vibromycin, which is available PO or IV and are roughly equivalent, as well as minocycline, also available PO or IV. They have a pretty broad spectrum of activity, as well as a wide variety of clinical uses. They cover gram-positives well, including community-acquired MRSA and strep, however they don't have very good strep coverage. They also cover gram-negatives, but not very well. They cover atypicals, which are commonly seen in STDs, as well as chlamydia and mycoplasma, also with community-acquired pneumonia. As such, they are used for community-acquired MRSA, skin and soft tissue infections, community-acquired pneumonia, Rocky Mountain's fever, and other tick-borne infections, acne, and other animal bites and obscure infections. The adverse effects of tetracyclines are somewhat similar to fluoroquinolones, with some differences. One, there is a risk of phototoxicity with tetracyclines, which you may not see with fluoroquinolones. As such, it's important to advise patients that they should use sunscreen or avoid sun exposure during treatment. There's also the risk of GI upset, which may be mitigated by taking with food. However, there isn't a very high risk of C. difficile that you might see with fluoroquinolones. And going back to that question that we answered previously, there is a risk of tooth discoloration, of deciduous teeth, primarily in pregnancy and in children less than 8 years old. It's also advisable to separate out from di- and trivalent cations, which would decrease the absorption of tetracycline derivatives, similar to how you might see with levofloxacin and the other fluoroquinolones. It's also advisable to take with water and remain upright for 30 minutes to avoid esophageal irritation. And patients should be counseled about this effect. In the next couple of slides, we'll talk about less commonly used tetracycline derivatives, which are commonly called novel tetracyclines. The first one is Tigecycline, or Tygacil, only available in IV formulation. This is indicated for complicated intra-abdominal infections, community-acquired bacterial pneumonia, and complicated skin and structure infections. However, it is typically a last-line agent for resistant organisms and not useful in bloodstream infections, as there is rapid tissue distribution, which prevents high adequate concentrations of the drug, which would work against bloodstream infections. In terms of spectrum of activity, it's very similar to the other tetracycline derivatives, except there is the additional benefit of gram-negative coverage, excluding the 3 Ps, which are Pseudomonas, Providentia, and Prevotella species. There is the additional benefit of anaerobic coverage, including Bacteroides, Clostridium perfringens, and Peptostreptococcus species, with the maintaining of atypical coverage. However, a severe limiting effect of this drug is severe nausea and vomiting, which often will result in patient discontinuation of therapy. This agent also has a boxed warning for increased mortality, which is another reason it is reserved as a last-line agent when other medications have failed. The next novel tetracycline that we'll discuss is Eravacycline, or Xerava. It is very similar to Tigecycline with a few key differences. Again, It's only available in an IV formulation and has very similar spectrum of activity. A few of the key differences are that it has very low rates of nausea and vomiting and low rates of infusion site reactions, so patients may tolerate this agent better than tigecycline. However, it is only indicated for complicated intra-abdominal infections. Again, it's important to reserve this agent last line for resistant organisms, and it is not useful in bloodstream infections due to the rapid tissue distribution. However, this agent is only indicated for complicated intra-abdominal infections. The final novel tetracycline we'll discuss is Omadacycline, brand name Nuzyra. This is a little bit different from the other novel tetracyclines in that it has an oral formulation available. This agent again is used last line for complicated skin and structure infections and CABP, or community-acquired bacterial pneumonia. It is not currently FDA indicated, but may be used for non-tuberculosis mycobacterium, as it has good in vitro activity. Otherwise, it has very similar spectrum of activity to the other agents. There is the potential for severe nausea and vomiting with this agent, similar to tigecycline. However, it's primarily with the oral formulation. Otherwise, it has similar rates of nausea and vomiting as Xerava or Eravacycline with the IV formulation. Again, it is last line for resistant organisms and not useful in bloodstream infections. Where you might see it being used, outpatient, is for non-tuberculosis mycobacterium, which is a very insidious disease state that can last for long durations of time. As such, the oral formulation is of high benefit. The next class of antibiotics that we'll be looking at are the macrolides, which work by binding to the 50S ribosomal subunit, thus inhibiting protein synthesis, and as a result are bacteriostatic. Macrolides are a class of antibiotics that you will see high use of in the outpatient setting. The first one, Azithromycin, or Zithromax, is available both as an oral and IV formulation, and it is primarily used for community-acquired pneumonia. Clarithromycin, or Biaxin, is only available as an oral formulation, and is only currently used for H. pylori infections. Erythromycin, or Irritab, is available both PO and IV, and it is primarily used for GI motility as it activates motilin receptors, resulting in uncoordinated peristalsis. Azithromycin is primarily used for CAP and VAP for its anti-inflammatory effects. It's not really used for coverage anymore, as there are increasing rates of resistance to azithromycin due to high usage, both inpatient and outpatient. All of these agents have DDIs, with the highest being clarithromycin. All of these agents also result in QTc prolongation, so you should caution with other drugs that result in that effect. They cover MSSA and strep. However, strep coverage is declining as a result of resistance. They also cover gram-negatives such as A-flu and MCAT. And they also cover atypicals, which is why these agents were traditionally used for community-acquired pneumonia. Azithromycin is probably the macrolide where you will see the highest use. It has very unique dosing, as it has a very long half-life. A Zpak is when you use 500 milligrams on day 1, followed by 250 milligrams through day 5. However, because of the long half-life, Zithromax keeps working for days 6 through 10. For mild community-acquired pneumonia, or when you have low suspicion of community-acquired pneumonia, you may also see the dosing strategy of 500 milligrams for 3 days due to that long half-life. As I mentioned previously, there is the potential for QTc prolongation with this agent, which may result in increased risk of cardiac arrhythmia and torsade de pointes. Patients at particular risk of this effect include those with known risk factors such as existing QT interval prolongation, a history of torsade de pointes, congenital long QTc syndrome, uncompensated heart failure, use of drugs known to prolong the QT interval, uncorrected electrolyte abnormalities such as hypokalemia or hypomagnesemia, or clinically significant bradycardia. You should also always weigh the risk and benefits of using this agent, particularly in patients with cardiac history. The next class of antibiotics that we will discuss are the aminoglycosides, which, similar to the tetracyclines, work by binding the 30S subunit of the ribosome, resulting in a bacteriostatic effect. Aminoglycosides have primarily gram-negative coverage, covering Enterobacterales species such as E. coli, Klebsiella, and Proteus, and in the case of some of these agents, Pseudomonas. They may also be used for beta-lactam synergy, covering such agents as Staph aureus, Strep species, and Enterococcus. Synergy works when a beta-lactam will poke holes in the gram-positive cell wall, and aminoglycosides are able to enter the bacteria and exert potent activity. This drug concentrates very highly in the urine as it is eliminated renally. As such, there is a high risk for nephrotoxicity with these agents, especially if they are dosed incorrectly. There is also the potential for ototoxicity. As such, it is important to avoid other nephrotoxic and ototoxic agents when using aminoglycosides. Typically, these drugs are used inpatient, and pharmacy will monitor trough and peak levels to maximize bacterial killing and minimize these toxicities. High peak extended interval dosing will help reduce the risk of nephrotoxicity. Some patients may be on these agents from continued therapy in the hospital, such as with long durations of therapy, such as with endocarditis. The next and final class of antibiotics that we will be discussing are the sulfonamides, primarily Trimethoprim sulfamethoxazole, which works by inhibiting folate production and synthesis. Specifically, Trimethoprim inhibits dihydrofolate reductase enzyme in the folate synthesis pathway. Sulfonamides act as a para-aminobenzoic acid analog, ultimately resulting in inhibition of folate synthesis, leading to bacteriostatic and bactericidal properties. This is a more detailed representation of the mechanism of action of sulfonamides. Sulfonamides, again, are acting on the para-aminobenzoic acid analogs. Trimethoprim is specifically acting on dihydrofolate reductase, ultimately resulting in impaired folate synthesis and bacterial cell death or stasis. Trimethoprim sulfamethoxazole, most commonly known as Bactrim, is available both in oral and IV formulations. It has very high clinical utility and covers gram-positives, including community-acquired MRSA. However, it does not have great strep or enterococcus coverage. It also covers gram-negatives, such as E. coli, and it is also used for fungal prophylaxis, such as with PCP or PJP. It is a very cheap antibiotic as well, and is on the $4 list. It is also important to note that this drug may be dosed differently depending on the infection that you are trying to treat. While there is high clinical utility with trimethoprim sulfamethoxazole, there are also adverse effects to be aware of, including allergic or hypersensitivity reactions, so it is always important to screen patients for potential sulfa allergies. An extreme rare adverse reaction associated with sulfa allergies is Stevens-Johnson syndrome, or SJS. This may result in skin sloughing off and may resemble a burn. This is considered a medical emergency, and patients should seek medical attention right away. Similar to tetracyclines, there is also the potential for photosensitivity, and patients should be advised to avoid excessive sunlight exposure or to use sunscreen when going outside. There's also the potential for GI upset. Crystalluria is another potential adverse effect, with sulfonamide crystals typically yellow in color and often resembling uric acid crystals. As trimethoprim is a weak aldosterone receptor antagonist, it may also result in potassium retention, leading to hyperkalemia, and patients with renal dysfunction should not use trimethoprim sulfamethoxazole. There is also the potential of bone marrow suppression if the drug is used at high doses. In terms of other things to be aware of, it's important to maintain adequate hydration to prevent clistruria. Use preventative measures in sunlight, such as avoiding excessive exposure and using sunscreen. And there are also important drug-drug interactions with warfarin and methotrexate. With warfarin, trimethoprim sulfa may result in increased INR, and this should be monitored regularly. It should also be avoided in patients with glucose 6-phosphate dehydrogenase deficiency, as this may result in anemia. Furthermore, it is also contraindicated in pregnancy, since these drugs are folate synthesis inhibitors and may result in kernicterus. That covers all of the agents that we wanted to look at specifically in this lecture. This is a summary slide for the different drugs which work by inhibiting DNA replication in the ribosome. These are therefore bacteriostatic drugs rather than bactericidal. We did not talk about fluoroquinolone, and this is likely a drug that you will not see used and is reserved for when less toxic agents have failed.